Thank you. We're now live.
Well, welcome to this panel discussion tonight on optimising therapy for chronic plaque psoriasis, entitled Plaque Psoriasis, the Evidence to Guide Practice Pathways. I'd like to start by acknowledging the traditional custodians on the many lands on which we are meeting throughout Australia, and recognise their continuing connection to land, waters and culture. We pay our respect to elders, past, present and emerging. And you're all encouraged to acknowledge and connect with the First Nations on whose land you are meeting tonight. And thank you very much for joining us tonight. It's a panel discussion, and I'd first of all like to introduce myself. My name is Professor Debra Rowett from the University of South Australia, and I'm the consortium lead for UniSA as part of the Value in Prescribing program. And I just wanted to go through a little bit of the webinar format tonight and what will be discussed. The webinar is funded by the Australian Government Department of Health through the Value in Prescribing bDMARDs program grant, and it's been developed with the guidance of members of the Targeted Therapies Alliance. And this webinar has been co-designed with the Australasian College of Dermatologists. Just a few housekeeping points, perhaps to get the most out of this webinar tonight or this panel discussion. If you can, rather than using the chat function, if you could please put your questions through the Q&A function, which is at the bottom of the screen. And we'll endeavour to answer some of those questions if there's time through the discussion tonight or at the end of the discussion. The resources that are referred to throughout the panel discussion tonight will be provided as a list with links at the end of the slides, which will be sent out to you. The webinar is being recorded and the slides will be available on demand recording of this webinar, which will be available in a few days. And those participants and those who have registered for tonight's webinar will be emailed the link. Similarly, the participation certificates will be provided for attending the webinar, and again, an email will be sent when that's available for you to download. There'll be a very short survey to complete at the end, and we would really value your input and you taking the time to give a few minutes to providing your feedback, as it is used to inform the future webinars and also this program more generally. So I would then like to welcome our panelists. And firstly, I would like to introduce and invite Associate Professor Peter Foley to introduce himself.
Thanks, Deb. G'day everyone. I'm Peter Foley, dermatologist in Melbourne. I work in private practice, and that funds all the fun things I do, like working at St Vincent's Hospital in Melbourne and the Skin Health Institute. I'm an associate professor at the University of Melbourne, head of dermatology research at St Vincent's in Melbourne, and director of research at the Skin Health Institute, where I've been involved in a lot of clinical trials and all of the biological therapies we use in psoriasis these days. The Skin Health Institute's been involved in the development program of these agents. I'm on the advisory board of all the companies that market these agents. I'm co-convener of the Australasian Psoriasis Registry. I'm part of the Australian Psoriasis Consortium or collaboration. I'm a counsel for the International Psoriasis Council. Have been on the steering committee for the group researching assessments in psoriasis and psoriatic arthritis. I have been the college's representative on the NPS MedicineWise Value in Prescribing program, co-convener of the Australian Treatment Goals for Psoriasis, and was one of the college's representatives on the PBS post-marketing review of use of biologics in psoriasis. So I have an interest in psoriasis, and sorry I've taken so long. Thanks, Deb.
No, thank you very much, and recognising the broad experience that you bring to the discussion tonight. If I could then invite Associate Professor Stephen Shumack to introduce yourself.
Thanks very much, Deb. So I'm Stephen Shumack. I'm a Sydney dermatologist
Sydney general dermatologist. I'm a clinical academic at the University of Sydney, and I'm also a staff specialist at the Royal North Shore Hospital of Sydney. I've also been involved in quite a number of clinical trials, particularly in the area of biological agents in psoriasis. And this has led me to be on a number, not quite as many as Peter, but a number of advisory boards over the years. And I've also been involved in a number of committees and groups that have interacted with a number of stakeholders, including government and the NPS system as well over the last few years. Psoriasis is one of my interests, and I'm particularly interested in targeted therapies. Thank you very much.
Thank you very much. And now I'd like to invite Associate Professor Michael Ward to introduce himself.
Thanks, Deb, and good evening. My name is Michael. I'm an academic pharmacist at the University of South Australia. My interest is in understanding the determinants of medicine's response, particularly biologic medicines. And for the past several years, I've been involved in the Department of Health Biosimilar Awareness Initiative related to interpreting the evidence around biosimilar medicines.
Thank you very much, Michael. And thank you all for your introductions, and also just to acknowledge the vast experience that you have. And there will be information at the end of the slides on any conflict of interest information that's been provided. So thank you again, and looking forward to the panel discussion tonight. And certainly we've got a number of dermatologists participating in the webinar tonight. We also have nurses and pharmacists and general practitioners. So we're really looking forward to this discussion. And tonight we're going to discuss areas such as the use of methotrexate in the management of chronic plaque psoriasis, the choice of biologics for first and second line biological therapies, the use of biologics in combination with other immune modulators, and the fundamentals of biosimilars and their role in therapy, and immunisation for patients with plaque psoriasis. So the Targeted Therapies Alliance, it's about the targeted therapies, and it's has been funded through the Department of Health program grant for Prescribing bDMARDs program grant. So it comprises the specialist consumer groups, the pharmacy groups, and it brings together that broad interdisciplinary expertise. And it's that broad interdisciplinary expertise that then was really underpinned the development of the evidence summaries, and an advisory group again with dermatologists' involvement, but also consumers, pharmacists, and other people with the expertise in gathering the evidence, synthesizing the evidence to bring together those evidence summaries to underpin the resources that have been developed for this program. So it's really about trying to bring together the best available evidence that's current and up to date, but in a way that also acknowledges the expertise and the clinical practice. And I suppose that's really where we wanted to focus our attention tonight by having a panel discussion around that evidence base in those areas that I've just highlighted. So in thinking about what the panel is going to discuss tonight, and perhaps firstly then moving to how the first topic that we have developed for discussion, which is really around the use of methotrexate in the management of psoriatic in chronic plaque psoriasis. And I might turn to perhaps Associate Professor Peter Foley in the first instance to really begin the discussion around the place of methotrexate in this condition.
Thanks, Deb, for giving me the opportunity just to comment on methotrexate. That it probably is the most frequently prescribed systemic agent for psoriasis, and there's been a lot of debate over the last few years as to how we should define psoriasis severity. And essentially, in reality, we work backwards. So there's mild disease, which can be treated or controlled with topicals alone, and then everything else is moderate to severe. So we need to move on from topicals. Phototherapy is a favorite amongst dermatologists, but methotrexate would be our first line systemic agent, partly because we're familiar with it, we think it's efficacious, partly because we are restricted in terms of access to other agents. We can't prescribe apremilast unless we've tried methotrexate. We can't prescribe biologics unless we've used at least one systemic agent. So it's our go-to drug. I think nowadays there's far more prescribing of methotrexate by dermatologists and our registrars than when I was a trainee. We're much more comfortable with it. We've got a lot better understanding of it. We no longer mandate liver biopsies at 1.5 grams. We no longer have a cap in terms of how much people require because we can monitor it more closely. And I think we've come to realise that a lot of the hepatotoxicity we see in patients with psoriasis on methotrexate, so as compared to our rheumatology colleagues who see pulmonary fibrosis, probably because rheumatoid arthritis is an autoimmune disease, psoriasis patients likely to be overweight, likely to be diabetic, likely to have dyslipidemia, likely to drink too much. So they've got all these hepatotoxic activities going on, which just makes the methotrexate more of an issue. So through their GPs, we can monitor or modulate that sort of component. Low-dose methotrexate has a huge role. We monitor bloods and we do fibroscans now, validated for hepatitis C, but seems to be very useful in managing patients with methotrexate. And we're more likely to seize methotrexate because of either GI upset or perhaps an elevation in liver function test rather than because the liver has packed up. So I've spoken for far too long, but I think methotrexate plays a huge role in a dermatologist's armamentarium. I'm perhaps not like our rheumatology colleague on the Sunshine Coast, Peter Nash, who feels it should be in the water supply. But I think every dermatologist should be comfortable and familiar with prescribing methotrexate.
Thanks very much, Peter, for that overview. And perhaps, Stephen, if there were comments that you would like to make about the place of methotrexate, and even also including what dose do you normally start with methotrexate, and when and how do you increase the dose of methotrexate?
Look, I think what's happened, as far as Peter was saying, is there's much more prescription of methotrexate, mainly because it's often being used as a stepping stone to get the patient on a biological agent. And a lot of people are therefore forgetting that it is actually quite an effective therapeutic agent for psoriasis anyway. So what's happened over the last decade and a half with the advent of biological agents, people are often starting at 10 milligrams, staying on 10 milligrams for 6 weeks. It's actually a relatively low dose, and 6 weeks is a relatively short period of time. And we're just using that, or many people are just using that to get a failure. Whereas if we start a little bit higher at 15 milligrams or even 20 milligrams, if we actually considered subcutaneous injectable methotrexate on a weekly basis rather than the oral methotrexate, if we perhaps waited a little bit longer than 6 weeks out to 10 weeks or even 12 weeks, we'll actually find that we get quite an effective therapeutic response for many of these patients, particularly those patients in the moderate category, where we're really struggling to get them over the line as far as biological agents are concerned. And as Peter mentioned, we're now much more comfortable because we're using it much more often with the safety profile. We can perhaps use that as a way of modifying our overweight patients, our patients who are drinking too much, to try and improve some of their comorbidities. And, you know, I'd recommend, you know, starting a little bit higher than that 10 milligrams and seeing what sort of response we'll get. And you'll know what will happen over that 6, 8, 10, 12-week period. And if it works really quite well, if the patients are tolerating it really quite well, you may actually have a cheap alternative to systemic therapy for our patients with moderate psoriasis.
Thank you very much for those comments. What about the dosage regimens for folic acid as part of that overall plan? Do you have specific regimens that you use for folic acid?
Again, the folic acid regimen is often mentioned to the patients when they go and get their scripts for methotrexate, particularly the first time. There's been lots of suggestions using it every day except the day that you use methotrexate. But I think even using it every day so people don't forget, I don't think there's any particular harm with that. And I usually just get people to use 1 milligram per day. I think it's just 1 tablet per day. What do you do, Peter? Something similar?
I think for me, the jury is still out, despite using folic acid for a number of years now. I worry because the little white pills, and I don't want people to take the little white methotrexate pill every day. So I have, at least initially, methotrexate on a Monday, and we've pinched this from Manisha Gupta in Sydney. Methotrexate on Monday, folic acid on Friday. Eat both of them once a week, 5 milligrams of folic acid. That way people can't inadvertently take their methotrexate 6 days per week or 7 days per week and folic acid 1 day per week. So, but then if people are pretty well controlled and have got GI issues, then I'll before looking at subcut methotrexate, I'll look at boosting the amount, because I agree with you. In psoriasis, methotrexate is not working by inhibiting folic acid metabolism, so we can push the dose. We've got wriggle room there.
Yeah.
And perhaps that's a nice segue on to talking. I know, Stephen, you were talking about subcut methotrexate, but perhaps that's a nice segue into talking a little bit more about the place of subcutaneous methotrexate and what you see are the benefits of using subcut methotrexate.
It's interesting, subcutaneous methotrexate tends to get a bit of a run every now and then amongst dermatologists when a particular dermatologist talks about it. And certainly in Sydney, there's a couple of dermatologists who routinely use this as part of their treatment for psoriasis. We know it's got higher bioavailability, so on a milligram per milligram basis, you get a better response. It certainly has less GIT side effects. So a little bit like Peter, if people are having trouble with nausea and GIT effects for a day or two around the dosage time, you want to fiddle around a bit with the folic acid. And if that doesn't work, you can switch over to the subcutaneous methotrexate, and you will often get quite a marked improvement in those GIT symptoms. It's quite easy to use. It's 50 milligrams in 2 mils. 1 mil is 25 milligrams, and you can change that around on the basis of what dose you want the particular patient to have. Quite easy for the patient to draw up and give themselves. Not particularly painful, and often a motivated patient, particularly those that have had issues with GIT side effects, are quite happy to switch over to subcutaneous methotrexate. I must say I used to use this quite often before the advent of biological agents, perhaps less so now, but it's certainly an option worth considering, particularly if you are getting a good therapeutic outcome with your patient on methotrexate, but nausea is the issue. Just flip over to subcutaneous methotrexate and maybe you'll be able to cure or fix that nausea or GIT upset problem.
Yeah. Peter, is that the same for you? And perhaps the acceptability of the subcut administration by your patients?
Yeah, I think patients are now aware of injections are the way to go with treating psoriasis, so we can use an injection. I'm actually a fan of the pre-filled syringe, so we can get 4 doses on the PBS now at doses ranging from 7.5 up to 25 milligrams pre-filled syringe. So patients, if they do fail, then we can move them on to biologics. They're familiar with self-injecting. The drawback is you can get a bottle of pills for the price that at 10 milligrams, you pay $40 for 15 tablets. It's 4 months of treatment as compared to going to the pharmacy every month. But I think, like Stephen, you see a decrease in the GI adverse effects, and I think the idea that you administer it subcutaneously, it's into the circulation, avoids that first pass effect through the liver. So it's not surprising the bioavailability is there. And I think there is some soft evidence that it's less hepatotoxic that way because it's not going straight to the liver, it's heading out to where it's doing its good. So huge fan. Just unfortunate that on the PBS they have to have failed or not tolerate oral methotrexate. But we can get around that.
Well, I was going to say perhaps when you were talking about the safety profile of methotrexate, given that it has been around for a long time and it is used in different conditions, obviously in much higher doses in cancer chemotherapy, but what we're focusing on here is the use of methotrexate in low dose in the treatment of psoriasis. But the safety around risk of cancer, both of you have mentioned around liver function and monitoring, but perhaps if there were particular safety issues that come up from your perspective with respect to methotrexate, perhaps Stephen, your thoughts on safety.
It's interesting how things have changed. Certainly, when I was a registrar or a younger dermatologist, we'd be quite particular about doing the blood tests, particularly liver function studies and a full blood count, within a week or two of starting the treatment, and then monthly for a while. I suppose what's happened over the years, particularly with the much increased use of methotrexate prior to biological agents, we've realised how safe it is. We've mixed with those rheumatologists, and they've told us, like Peter Nash, that it should be in the water supply. So we've become much more comfortable with it. And I must say, I tend to just do baseline liver function studies for blood count. I'll repeat that within the first couple of weeks of starting the treatment. And then I might do it about a month later, and then probably every 3 months or so after that for a while. And if people are stable on the treatment, even less frequently than that as we move forward. Skin cancers with the methotrexate, I mean, there's been no real signal. It's an old medication. It's used quite commonly in people with rheumatic disease. Older people that may have issues with skin cancer, we're not seeing a particular significant signal there. So I think that's really quite safe. From the dermatology perspective, I think from our perspective, the biggest issue is the GIT symptomatic side effects and issues associated with liver function abnormalities, particularly in people who may be drinking more than they actually say, or those that might be a little bit more overweight as time goes on.
Thank you very much. Peter, did you have anything further to add on the safety side of methotrexate?
Yeah, I think we got to warn people that there's nuisance side effects, mouth ulcers, occasionally some hair shedding, the GI side effects. Like Stephen, I don't over-investigate. I probably, because of my academic interests, I do check people's glucose and lipids at the start because I want them to be managed by their GP if they have the comorbidities of diabetes or dyslipidemia. I make sure their kidneys work, given that it's renally excreted, and it's mostly monitoring FBE and liver function. Everyone varies a bit, every 2 to 6 months. I warn people there's a drug that works on the immune system, so in theory, they're at increased risk of infection. In theory, they're at increased risk of cancer. We certainly know psoriasis patients have higher rates of some cancers, particularly hematological or lymphoproliferative and non-melanoma skin cancer. So yeah, we monitor it. The great thing about if there's a risk associated with skin cancer is we're stripping the patients off to look at their psoriasis. So we have the opportunity for opportunistic skin cancer screening. So yeah, very comfortable with it.
And I suppose one of the opportunities through this program and working with yourselves and also with Psoriasis Australia has been the development of these resources, because low-dose methotrexate for plaque psoriasis, there are a number of myths around methotrexate, and so these resources were presented and developed in partnership. So highlighting what the facts are and then what the myths. And one of those myths is thinking about the use of methotrexate in the context of plaque psoriasis. It's not being used as cancer chemotherapy, and it's really important because consumers can receive a range of information from a range of resources, not least the internet when they're perhaps looking up when they've started on a new medicine. So these resources have been developed, to really highlight that methotrexate is taken once a week when you take it the way that it has been prescribed, but giving them that information themselves in a really positive and proactive way for the consumer. And NPS has developed the other resources around how to support them take that low dose methotrexate and when to contact you as the doctor, what to do urgently, as soon as possible, and then regularly. So building from those things that you've just highlighted, these resources have been developed for consumers. And hopefully they will be something that will be of value to dermatologists to use with their patients. They have been designed as health professional mediated resources as well to have those conversations, and also the NPS MedicineWise app to help support the consumers themselves taking these medicines, which are once weekly.
Deb, if I could just say, the terminology low dose methotrexate on these forms is actually very good because, traditionally we just talk about methotrexate, referring to low dose methotrexate from the dermatology perspective. But it's useful if the patient sees this, then when they look it up on the net, as they all do these days, they're not scared off by issues associated with the anti-cancer type dosages of methotrexate that they'll see on the internet. So I think that alone is really an excellent aspect of handing over these brochures and these educational materials to our patients.
Yeah, that's right. But also taking into consideration the comments that you made earlier, as the clinician, you'll be exploring a range of doses for that individual patient, but overall they are low doses of methotrexate, and perhaps not just starting with the lowest dose and then titrating, as you've highlighted, up to the sort of doses that you would use in practice. So obviously, one of the other things is that in practice, in clinical practice, there's often special considerations. So pregnancy, what are some of the special considerations that you might have with methotrexate?
Do you want me to run with this one? So, obviously,
Thank you, Peter.
in females of childbearing age, methotrexate is contraindicated post-conception. But it has such a short half-life where we're pretty comfortable once a woman decides she wants to fall pregnant, off for a month, and then it's out of their system. So it's not really an issue. If you want to be conservative, we can say 3 months. I think the dermatology textbooks still say that men need to stop drug for 3 months before planning to father a child. But the issue really in men at the doses we use relates to perhaps decreased sperm count rather than affecting sperm quality. So I think it's just part of the discussion, and it's probably okay for men to be fathering children, but it's got to be not just carte blanche, go for it. It's part of the discussion saying the evidence is that it's not an issue. So that's my current approach.
Thank you very much, Peter, for that. I think perhaps in the interests of time, we might move on to immunisation, if that's okay, as a very topical area at the moment. And again, we've got the evidence around vaccinations, but interested in practice, what you're seeing at the moment, particularly with respect to COVID vaccinations, but also with zoster as well.
I think, as this slide says, vaccinations should probably be administered and completed at least a couple of weeks before starting the treatment, basically to get the best effect out of any vaccination. We know that perhaps with methotrexate and perhaps with cyclosporin, there might be a reduction in the response rate to the COVID vaccine. And that's certainly been talked about, and there's been a little bit of literature on that. But if it is, it's a relatively minor effect. And I think if people are concerned, they might perhaps miss methotrexate for a week or two before having the COVID vaccine or a booster of the COVID vaccine. But I think the response is going to be fairly minimal anyway. Peter, have you got any further comments on that?
No, I agree with you, Stephen. I think nowadays we're quite focused on having patients vaccinated before they start systemic therapy, because we're looking at long-term agents that work on the immune system. So we're trying to get things up to speed. As it says up on screen that nowadays live attenuated vaccines probably all right with low-dose methotrexate if it's used as monotherapy, and really with the inactivated zoster vaccine becoming available,
yes,
there is the option to vaccinate patients who are immunocompromised. And the COVID vaccine is an interesting one. It would seem that cell-mediated response to the vaccines isn't affected by methotrexate, but antibody levels might be down. So give a booster.
Thanks very much for that. And again, perhaps there's just when we were talking before about monitoring, a question's just come up. I'm not sure, Stephen or Peter, if that you can see the question there around monitoring patients on methotrexate with the ProCollage 3 test or FibroScan, and if so, when do you order these tests?
It's easy in Australia to do a FibroScan. All the major teaching hospitals have FibroScans available. ProCollagen 3 is actually quite difficult to get done in Australia, so we tend to use FibroScan. And I think the jury's still out as to when you should do it. Probably after a couple of years, we would suggest doing a FibroScan. That's our approach. So,
Stephen?
Yeah, really much the same. Probably depending a little bit too on the dose. If somebody's on, 7.5 or 10 milligrams, I might go out to, 3 or 4, even 5 years. Particularly if there's no abnormality in the liver function studies. If people are on a moderately high dose, like 20 milligrams or 25, I'd probably be keen to do that at 2 to 3 years. But yeah, relatively easy to organise a FibroScan.
And thanks, probably good to get one up front at the start, so you've got a baseline to work from.
So that then enables us to perhaps move on to thinking about line of therapy with respect to the biologics, where to start and to move on to. Perhaps, Peter, would you like to go first there?
Yeah, Stephen was kind enough to invite me up to the Royal North Shore meeting in Sydney last weekend. I spoke on where to start with biologics, and it really is horses for courses. It's trying to line up the right biologic for the patient in front of us, the comorbidities, whether they're planning pregnancy, whether they have psoriatic arthritis, what their lifestyle allows. I think psoriasis, no other issue coming into it. The newer agents have better efficacy. So those targeting interleukin 17 and interleukin 23 are more efficacious than our older agents. The interleukin 17s are probably better than the 23s at this stage. The evidence is they're a bit better for psoriatic arthritis. So I think we're lining up efficacy. The safety profile is pretty good, but it's really we're fortunate with psoriasis that our new biologics are more efficacious than our old ones. The rheumatologists don't seem to be having that incremental improvement. If you look at the responses in the rheumatological indications, they're pretty much all the same. So newer agents aiming for higher efficacy, they're more targeted, so the safety profile looks better. They're more convenient because they're either monthly or 2 monthly or 3 monthly. So it's trying to line up the drug to the patient in front of us.
Yeah, absolutely. Thank you. Stephen, were there other comments around line of therapy that you wanted to add?
Look, not really, other than, to agree with Peter as far as those things are concerned. I mean, you look at, and I know we're just going to talk about this in a minute, about, comorbidities, and there are a number that we're perhaps less likely to use, some of these agents like the TNF blockers or the interleukin-17s. The other thing you've got is convenience for the patient. Some people are much happier with injecting themselves every 4 weeks or 2 weeks or weekly, and other people just prefer, the 3 monthly injections. So there are a number of different options for first-line therapy. And of course, the other thing is, whether or not they're coming back into a treatment. Somebody might have stopped treatment for a particular reason, and then you want to restart that same therapy, and it might be one of the older biological agents that's working particularly well in that patient. Peter's got his hand up.
It was really, Dad, that we're quite fortunate again in the world of psoriasis that all of the new agents have done head-to-head studies against the older agents. So we have efficacy and safety data that we can look at. And so rather than indirect comparisons, we can actually look at head-to-head studies.
Yeah, that's very good. And also, what about in loss of response, when you've the use of the biologics? What are some of the treatment regimens that you might use where you're seeing loss of response?
Yep, go, Stephen.
You go, Stephen.
I was just going to say, particularly early on when we didn't really have much choice, we'd think about adding some other therapies with the biological agents. So you might want to maximize or optimize topical therapy. Sometimes, just prior to the next injection. So some of the 3 monthly injections start to wear off a little bit at week 10 or week 11. So you might want to add those in. Sometimes adding in some phototherapy periodically for those patients as well. Another alternative would be methotrexate, and we can use that as a systemic agent with the biological agents. And often the companies that make these particular products, you can discuss with those, and you might want to increase the dosage. So instead of having 12 weekly injections, you might alter that to 8 weekly injections to get an increased or a better response. So often it's better to try and optimize the therapy with the agent that you're actually on, rather than blindly or rather quickly switching to another agent. Of course, that's another thing that we can do, but it's maybe the second or third line, rather than trying to improve the therapy with the agent that you've actually started with, which may indeed be the second agent or third agent. And one of the worries that we have, changing quite often, are we getting a less of a response to the second, third, and fourth agent as we move along? Peter.
Yeah, look, I agree entirely, Stephen. It's unfortunate that we don't have flexibility with the PBS, but the companies are pretty good. There's so much competition, they're pretty good at providing compassionate supply. So if the maximising combination therapies, topicals, methotrexate, and UV, is not efficacious, we can either increase the dose or shorten the interval. And if that's not effective, then we can move on. Sometimes we move within class, sometimes we change class. It all depends a bit on whether we think it's a lack of response, we change class. A loss of response, we'll often look at what other agents might be in that class, particularly if there's been no safety issues. So sometimes we switch class, sometimes we stay within class.
And really key points around maximising the therapy, supporting the patient, looking at some of those factors to optimise that therapy, perhaps having a higher threshold to switch or change therapy, seem to be some of the key points that you were both raising. But also there is, factors that need to be considered with patients with their comorbidities with these particular agents. And just, I suppose, briefly, just thinking about what some of those factors are. We've got a couple of those comorbidities because they're common comorbidities. Peter, did you want to have comments around some of your kind of clinical reasoning and thinking around choice of therapy and comorbidities?
I think what I was coming back to, I don't have a set drug for everyone that walks in the door. I think psoriatic arthritis makes a lot of the decision. The TNF antagonists approved for psoriatic arthritis, the interleukin-17 antagonists, ustekinumab, guselkumab. So we've got 7 drugs approved for psoriasis and psoriatic arthritis. A number of them now have done head-to-head studies, particularly against adalimumab, which was considered gold standard. Joint efficacy is similar, but skin response is better in the interleukin-17 antagonist. So I tend to head down that line with psoriatic arthritis. Definitely avoid the interleukin-17 antagonists in people with inflammatory bowel disease.
Yes.
Thankfully, conditions like multiple sclerosis, the sort of various autoimmune conditions are not common, but we do tend to avoid people with immune dysregulation. We don't tend to use patients with lupus. We don't use the TNF antagonists. And the heart failure data really relates to really high-dose methotrexate, high-dose infliximab on patients with such severe heart failure they couldn't walk from the waiting room anyway. But if someone's got significant heart failure, definitely avoid the TNF inhibitors. We also tend to avoid the TNF inhibitors in patients that have major issue with chronic infection. We don't want to use the TNFs if patients have a history of or there's issues with tuberculosis or other opportunistic infections. So the infective complications perhaps a little bit more of an issue with the TNF antagonists. But yeah, it's really trying to line up the right drug for the patient sitting in front of us rather than just using one agent or 2 agents.
Yes. Stephen, I might, unless there's key points that you would like to raise in addition to those, I might move on then to Michael, your presentation around biosimilars, the evidence and the practice of biosimilars. So over to you, Michael.
Yeah, thanks, Deb. So picking up on some of those comments that both Stephen and Peter have made around some of the challenges around biologics and the PBS, one of the really key factors is going to be making sure that where we can, that we're trying to drive the cost effectiveness of medicine use as much as we possibly can. And for some of the biologics, obviously, that we've spoken about, the older ones, the ones that are perhaps not first line now, but maybe have a role in particular patients, their patents have expired. And so we now have the opportunity for alternative manufacturers to enter the market, so the biosimilar manufacturers. And so the question then is, what is the evidence base that is being built to support the use of those medicines? And what are some of the concerns that might get in the way of achieving some of the cost effectiveness improvements that we might see from those medicines? So if we think about that, we really have to take a look at the regulation pathways. So on the left-hand side of this screen is the pathway we'd all be familiar with for the registration of a medicine for the first time, so that phase 1, phase 2, phase 3 clinical trial process, which is about demonstrating safety and efficacy of those medicines for the very first time. On the right-hand side, we have the biosimilar pathway. And it's really leveraging off of all of that wealth of experience that we have gained from the reference product. So rather than trying to replicate the studies that were conducted on the left-hand side, what this process is doing is saying, let's take all of that knowledge that we've gained from years of using the reference product or the original brand, and let's then look and see if another manufacturer comes along and compare the 2 products. And so down the bottom right-hand side there, you can see a structure of a monoclonal antibody. And the process here really starts with a very in-depth, a really exquisite analysis of the reference product and the biosimilar manufacturer's product. It's really quite fascinating science. It's very detailed analysis across multiple batches of reference product and the potential biosimilar. And it's only then if a product has demonstrated to be sufficiently similar to the originator product that it would progress on further up that pathway into some phase 1 studies, looking to compare the PK. If the molecular attributes are right from those analytical studies, then you would expect the PK to be exactly the same. And then from there, if the PK is shown to be same, then they'll be doing phase 3 studies looking to compare efficacy. Now, this isn't the same sort of efficacy study we saw on the left-hand side. Remember, we're not trying to demonstrate efficacy for the first time. What we're trying to say is the efficacy the same as the reference product? And so these phase 3 studies are designed a little bit differently. They might, in the case of psoriasis, for example, aim for a PASI 70 or 75 at 16 weeks of therapy as an endpoint to demonstrate a equivalent effect in those patient groups. And then obviously then, given that this is a more truncated clinical development program, because it's leveraging off that knowledge that we already have, the question then is, what is the real world experience? What has it been to this point? And so if we just move to the next slide, one of the comments that comes up is, well, what about switching? So patients may have been stabilized on one of these therapies. Is it okay to switch from the reference product to the biosimilar? Can they switch from the biosimilar to the reference product? And down the bottom, what happens in the real world where you have a patient who could potentially switch back and forwards multiple times? The initial studies often didn't include switching. You don't see that in that pyramid on the right-hand side. But what you do see now in a lot of the studies is they will include some switching after the original equivalence endpoint. So then we're building an evidence base around the use of these medicines, these biosimilars. But what does that real world evidence show, particularly in terms of outcomes we've seen with switching in practice? And so if we move to the next slide, what you can see here is for infliximab, so obviously not one of the biologics that we'd be using extensively in psoriasis, but is one that we have the most experience with in terms of biosimilars. You can see across a range of indications, be it people with rheumatoid arthritis in the top paper there, patients with inflammatory bowel disease, and patients with psoriasis. What you can see is a large number of authors now reporting real-world experience of switching between originator and biosimilar, and suggesting that the outcomes they're seeing are the same as they would expect. They're not seeing any alarming signs of immunization, development of anti-drug antibodies and those things that had been proposed as a concern that might lead to some of the loss of response that we were talking about just a little bit earlier. So overall, the signs have been quite positive, but that's not to say they've always been positive. There are some examples where people have perhaps had a more challenging journey. And this is just an example of one of those. You can see here, this was an institution that implemented a switching program where they had a steering committee to be involved in designing that switch. And what you could see is that some of those patients perhaps went on to relapse. The circles at the bottom there are showing some of the treatment patterns. So some patients started on originator, they switched to the biosimilar, they went back to the originator, switched back to the biosimilar, and a variety of other patterns. And one of the questions you have to ask yourself is, what's driving that? What's the clinical decision-making processes that are prompting people to change between those agents in that way? And what does that do to patient confidence if their therapy is being chopped and changed? And what we see in the literature is actually that a lot of these poor responses people are describing to changing to a biosimilar is often in subjective matters of disease control rather than any of the more objective things. It's a vague set of symptoms the patient's reporting. They might be then changing back as a result. And you have to ask yourself, well, what is the molecular basis for making that change, given that very exquisite characterization that these molecules went through in that very first step of that regulatory evaluation? And so really that probably leads us to one of the most important things here, and that is that in influencing any of these discussions around biosimilars is, if we just move to the next slide, is that perceptions are critically important. And that might be the perceptions of the patient, that might be the perceptions of the prescriber or other healthcare practitioners they're being involved with. But what we certainly know is that the phenomenon of nocebo, that is where people hold a negative perception of a product, perhaps because it's perceived as being a cheaper, inferior product, can have adverse effects, particularly in terms of those subjective measures of disease control. And so it's really important that in thinking about improving the cost effectiveness of biologic medicines, that we are mindful of perceptions and how they might impact treatment. And in particular, one of the things we need to be thinking about is the device, because obviously at the end of the day, that's one of those critical things that the patient will actually engage with. And there can be differences in the devices, and the device, in fact, may be one of the most important things that the patient recognizes. So having that open conversation with them about those things is critically important. So if we move then to the next slide. So obviously the best way we can address this risk of nocebo is through education, through educating ourselves as healthcare practitioners, but also through educating patients about the medicines and the fact that there are benefits to be gained through improving the cost effectiveness of these agents.
Thank you very much, Michael, for that really fantastic overview, but also, really highlighting the issue around the devices and around patient education and choosing, again, the right medicine and the right device for an individual patient. So perhaps, Peter, first, in your practice, again, what have been some of the key issues around the use of biosimilars in your practice?
As you've already mentioned, or as Michael mentioned, it's not, we don't prescribe a lot of the TNF antagonists now, so it's perhaps a little bit less relevant. In the Victorian public hospital system, there's a tender process in terms of which infliximab is available, and I think everyone's comfortable with the one-way switch, and I think people get a little bit nervous with biosimilar A is similar to originator, biosimilar B is similar to originator. Is there similarity between biosimilar A and B? And with agents like infliximab or adalimumab, where anti-drug antibodies and immunogenicity might be a bit of an issue, one-way switch, great, drives the price down, cheaper drugs for the originator as well as the biosimilar. It's great as a taxpayer to have cheaper agents. And we do use the TNF antagonists, inflammatory bowel disease, if they've got concomitant arthritis, if they've got uveitis, hidradenitis suppurativa. We know the TNF agents are effective in a large range of disease. So we use them. In terms of the self-injected biosimilars, it's really when the patient comes in and said, oh, they've changed the device. And it's like, no, they haven't. It's a different agent. So as long as the pharmacist is educating the patient, because we know that the originator products have been fantastic with their support programs in terms of training patients on how to use their particular devices or syringes. So as long as that education is maintained, one-way switch, absolutely no concern at all. And as a prescriber, it's easier once we get to that second continuation, which is what most of our TNF antagonist patients are on, subsequent continuations. It's just a matter of, do they meet the criteria, put in a streamline number. None of this paperwork that we've got to wait for Hobart to approve. And I switched to pharmacist patient from originator to biosimilar adalimumab a couple of weeks ago when he came in, said, I tried the biosimilar, no issues, my skin's still clear, my inflammatory bowel disease is quiescent, and my joints are excellent, so let's go for that.
Yeah. And
then he was wrapped at all. I could actually hand him the script before he walked out the door rather than relying on me getting the prescription to him. at some later time point.
No, thank you very much.
So
for
it was
that,
a very
Peter.
positive experience.
Oh, that
For
sounds
me
really
and the
good.
patient.
Thank you. Yeah, and time, some of those really practical things are really important. And just perhaps moving on in the interest of time, there's a number of resources that have been developed, and the Society of Hospital Pharmacists have developed a quick reference guide. It's available online. It includes information, really practical information. For example, what the devices are, whether they contain citrate or not citrate, a useful resource there, hopefully for practitioners. And also the KTAG guiding principles. Michael was chaired that group, and the biologics and biosimilars best practice, and particularly for those working in hospital, is a really useful and recent version 3 came out in October 2021, so up to date and practical. So there's a number of resources that are available, and they will be included in the information that's emailed out to you. And so there are many resources available to help you and your patients, and the list of further reading and resources plus these webinar slides will be made available on the NPS MedicineWise page tomorrow. There was just one question that, again, it's probably a long question, and that is around how to select a biologic from the array in front of you. Does speed of onset really matter that much in a lifelong illness? Stephen, did you want to take that question up before?
I think Peter's answered that to a certain extent when he was talking about, thinking about the comorbidities as far as the patients are concerned. Are the patients happy with self-injecting? Do they want, 3 monthly injections? Look, I think speed of onset is relevant in a certain group of patients, particularly younger patients that may want to be, cured of their psoriasis yesterday. And certainly, the TNF blocker, the IL-17 agents are much faster than the TNFs, except for perhaps in fliximab, and certainly faster than the IL-23. So you may want to consider that. The IL-17 in those patients if you were starting them on something new. But realistically, after they've been on these medications for 2 or 3 months, by the time you're seeing them for their second script, these days they're all usually very happy with the responses, particularly to some of the newer agents.
And just one question, perhaps, Peter, and that was that came through, which was around any advancements in the prevention of psoriasis, was one of the questions that's come through on the Q&A. Peter, any quick comment?
Very short answer, no. I think it would be fabulous. The twin studies, the lack of complete concordance with identical twins, sort of about 70% concordance, shows that it's not just genetics, environment plays a role. What is it about that 30% that don't develop psoriasis? Once someone's nutted that out, perhaps we will be able to look at preventative strategies, but at the moment, it's a bit of a holy grail.
Thank you very much. So these are the resources, and as I said, you will get the links to these so that you can access this information after this webinar. I'd like to just thank again the panelists, Peter, Stephen, Michael, for their contribution tonight. And we would really value for the participants online if you would complete the survey that will pop up at the end of this webinar. Participation certificates will be provided and an email will be sent when these are available to download. So again, thanking you all very much for your contribution tonight, and it's been very much appreciated. And these resources, as I said, will be available. We've tried to answer the questions as they have arisen throughout the evening, but if there are further questions, I hope we may be able to respond to those people specifically, but otherwise the resources have been made available. So thank you again very much, everyone.
Thank you very much. Good night.
Thanks for the invitation to participate.
Thank you, Peter. Thank you, Stephen. Thank you, Michael.